Welcome to The Critical Edge, the no-nonsense podcast, breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Glad to be here. Let's get into it.
Yeah, so if you are a United States-trained trauma or surgical critical care surgeon listening to this right now, your daily reality is it's a relentless, multi-front battlefield. You know exactly what I mean.
Oh, absolutely.
You are standing there in the surgical intensive care unit. You're running massive transfusion protocols. You're managing open abdomens with complex interocutaneous fistulas.
Right. Trying to resuscitate severe traumatic brain injuries with those soaring intracranial pressures.
Exactly. And you're trying to meticulously balance hemodynamics on patients who are requiring triple vasopressor support.
Yeah.
You are doing all of this to keep your patient's organs from completely failing under the immense physiological stress of major trauma and aggressive surgical intervention.
And that is exactly what our mission is for today's deep dive.
Right. We are dissecting the comprehensive book chapter, Acute Kidney Injury and Renal Replacement Therapy in the Surgical Intensive Care Unit, authored by Gamadi, Flint, and Durham. We are extracting the exact methodologies, the pathophysiological nuances, and the critical care trial data you need to manage the most common and, frankly, often the most frustrating organ system failure you face. The kidneys?
The kidneys. I mean, the stakes in the SICU regarding renal failure are they're extraordinarily high. The epidemiology presented in this source text, it establishes a pretty grim baseline.
Yeah, lay those numbers out for us.
So acute kidney injury, or AKI, it complicates approximately 50% of all intensive care unit admissions.
50%. Half the patients you hand over on morning rounds are fighting this.
Exactly half. And in the specifically critically ill, hospitalized surgical population, up to 90% of these AKI episodes are driven by a combination of profound ischemia and nephrotoxin exposure.
Ischemia and toxins are bread and butter in trauma.
Right. But the data point that absolutely mandates our attention is the mortality shift. Listen to this. If a patient's AKI progresses to the point of requiring renal replacement therapy, RRT, their 90-day mortality skyrockets to between 44 and 60%.
That is massive.
It is. And if that renal failure occurs within the context of multi-system organ dysfunction syndrome, which, is frequently the case in florid sepsis or massive trauma, that mortality rate touches 90%.
90%. I mean, those numbers dictate how aggressively we have to manage these patients. But the sheer ambiguity of AKI in the trauma bay and the SICU makes it a formidable enemy.
It's incredibly ambiguous.
Right. We are dealing with a massive medical and economic burden, yet there is no single gold standard for diagnosis.
Yeah.
We don't have the luxury of a histopathologic confirmation at the bedside.
Yeah, you can't exactly just biopsy a kidney at 3 a.m. in a patient with a pelvic binder and an open chest.
Right. And there is no uniform clinical picture. An acute creatinine bump in your SICU might be the first, highly subtle warning sign of a subclinical anastomotic leak in early sepsis.
Or it might just reflect the natural progression of a patient's chronic hypertension and diabetic nephropathy in the setting of acute physiological stress.
Exactly. So we need to go beyond the textbook definitions today. We need to dissect the physiological blind spots of our standard labs, analyze the exact statistical limitations of the major RRT trials, and figure out when to hold the line and when to actually pull the trigger on dialysis.
And to do that effectively, we have to immediately confront the inherent flaws in how we actually measure renal function.
The illusion of measurement.
Right. In a heavily monitored SICU patient, we track cardiac output with pulmonary artery catheters or arterial line pulse contour analysis.
We measure cerebral perfusion pressure directly.
Exactly. But we cannot easily or practically measure the glomerular filtration rate, the GFR, directly in a crashing patient. We just can't.
Which brings us back to that illusion. Because we can't measure GFR directly, we're forced to rely on the classic, highly flawed surrogates. Blood urea, nitrogen, and creatinine. Let's tackle BUN first.
Okay, let's do it.
When you are managing a complex polytrauma, BUN seems to fluctuate with almost no correlation to what the kidneys are actually doing. Why is BUN such a notoriously unreliable marker in our specific population?
Well, BUN is a physiological trap if you view it purely as a renal marker in the surgical population. It's the end product of protein and amino acid catabolism.
Right.
Under stable homeostatic outpatient conditions, the kidneys excrete 80 to 90% of the body's total nitrogen. So the theoretical assumption is that if GFR drops, BUN rises proportionally.
But in the SICU?
In the SICU, BUN is held hostage by variables that are entirely independent of intrinsic renal function.
Give me some examples of that.
High protein total parenteral nutrition drives it up.
Sure, TPM.
Profound starvation and liver failure drop it. But for the trauma surgeon, the massive confounding variable is the reabsorption of blood.
Oh, the hematomas.
Yes. If you have a patient with a grade 4 splenic laceration managed non-operatively, or a massive retroperitoneal hematoma from a vertical shear pelvic fracture,
Or an active upper gastrointestinal bleed.
exactly, their BUN will skyrocket. The body is absorbing and breaking down that immense sequestered protein load.
So you're just watching protein digest.
Right. You can watch a patient's BUN double over 48 hours while their actual GFR remains perfectly stable, simply because they are digesting a hematoma.
So relying on BUN to dictate fluid management or, nephrotoxic drug dosing in trauma is essentially flying blind. We basically toss BUN out as a solitary marker and rely on creatinine.
We do, but creatinine comes with its own major baggage.
Right, because creatinine is formed in the skeletal muscle by the non-enzymatic degradation of creatine. That alone makes it a highly volatile marker in our specific patient population, correct?
Exactly. Creatinine production is a direct reflection of muscle mass. In a healthy 25-year-old trauma patient, it might be a reliable baseline.
Sure.
But consider the 85-year-old cachectic patient who fell and suffered a subdural hematoma.
Or the 40-year-old trauma survivor who has been in your SICU for 3 weeks, battling ventilator-associated pneumonia and experiencing that profound muscle-wasting catabolism of chronic critical illness.
Yes, exactly. Their baseline creatinine generation is severely diminished. So a serum creatinine of 1.0 milligrams per deciliter in that cachectic patient
Might actually represent a massive reduction in GFR.
right, a profound renal failure, whereas that exact same 1.0 would be entirely normal in someone with adequate muscle mass.
And beyond muscle mass, we have to look at how the nephron actually handles the creatinine molecule itself. It's not a perfect filtration marker.
Far from it. The fundamental assumption when using urinary clearance of creatinine to estimate GFR is that 100% of the creatinine in the urine arrived there via passive glomerular filtration.
But that's not what happens.
No, the physiological reality is that while it is primarily filtered, a clinically significant amount of creatinine is actively secreted by the proximal renal tubules directly into the lumen.
Actively secreted, meaning it bypasses the glomerulus entirely.
Exactly. Because of this unaccounted active tubular secretion, measuring creatinine clearance will systematically overestimate the actual GFR, sometimes by as much as 20%.
20%. I mean, a 20% overestimation is the difference between a therapeutic trough and profound toxicity when you are dosing an aminoglycoside.
It's massive.
It's the difference between a patient waking up from sedation or remaining paralyzed because they aren't clearing a renally excreted drug. So to mitigate this overestimation, we use mathematical equations based on epidemiologic data. We all learned Cockcroft-Gault and then the modification of diet in renal disease, or MDRD equation.
The evolution of those predictive equations really highlights our struggle to quantify renal function accurately. Both Cockcroft-Gault and MDRD utilize variables like age, weight, and sex to adjust the raw serum creatinine value.
Trying to account for those muscle mass discrepancies you just discussed.
Right, but there is a vital statistical nuance regarding these formulas. They are inherently flawed, and their inaccuracy is most pronounced in patients with near-normal GFRs.
Near normal GFRs. Why is that?
Well, the MDRD equation was developed and validated in cohorts of patients who already had established chronic kidney disease. So when you apply MDRD to a trauma patient with healthy kidneys, it significantly underestimates their true GFR.
Which is precisely where the chronic kidney disease epidemiology collaboration, or CKD-EPI equation, comes into the picture.
Correct. The CKD-EPI equation, developed by Levy and colleagues, was explicitly designed to correct this specific mathematical bias.
It uses the same 4 variables, right?
Yes. Age, sex, race, and serum creatinine. But it models the relationship between GFR and serum creatinine differently, particularly at those lower serum creatinine levels.
So for a patient with a near-normal GFR, the CKD-EPI equation provides a much tighter, more accurate prediction of true filtration than MDRD.
Exactly. If you are tailoring highly toxic antimicrobial regimens in a patient with seemingly normal renal function, CKD-EPI is the superior mathematical tool. You want that accuracy.
Okay, so our baseline diagnostic tools are essentially funhouse mirrors. This makes defining, staging, and studying acute kidney injury incredibly difficult. Let's trace the historical context of how we classify AKI, because understanding the evolution of the definitions really explains the blind spots in the current literature.
The history of AKI classification is driven by a desire to capture the injury earlier in its pathophysiological course.
Right. We started with rifle.
Yes, the first major, universally adopted consensus definition was the Rifle criteria, established in 2004. Rifle categorized patients into risk, injury, failure, loss, and end-stage renal disease.
It was a huge deal at the time.
It was a massive step forward because it definitively linked increasing Rifle stage to a statistically significant increase in short-term mortality. It proved that AKI was not just a bystander in critical illness.
It was an independent driver of death.
Right. However, as outcome data matured, researchers realized that Rifle was missing subtle injuries. Even minor transient bumps in serum creatinine were heavily associated with mortality.
And that realization led to the 2007 revision by the Acute Kidney Injury Network, or AKIN.
Yes. AKIN made two critical adjustments. First, they recognized that an absolute serum creatinine increase of just 0.3 milligrams per deciliter was clinically significant and merited staging.
Just a 0.3 bump.
Exactly. Second, they implemented a strict 48-hour time limit. To be classified as an acute injury, the creatinine change had to occur within that acute window, helping to differentiate AKI from the slow progression of chronic kidney disease.
Which brings us to the current global standard utilized in almost every modern critical care trial. The 2012 Kidney Disease Improving Global Outcomes, or KDIGO criteria.
Yes, KDIGO is the standard.
If we are evaluating the START, AKIA, or IDEAL ICU trials later, we have to understand exactly how KDIGO categorizes these patients. But there is a massive clinical prerequisite to applying KDIGO that gets ignored during rapid morning rounds.
Oh, it is the most frequent misapplication of the criteria. KDIGO staging applies exclusively after the patient has received adequate fluid resuscitation and after you have definitively ruled out urinary tract obstruction.
So if you have a penetrating trauma patient who arrives in hemorrhagic shock, hypotensive, and oliguric,
they do not inherently have KDIGO-defined AKI at that moment. They have profound intravascular volume depletion.
right?
You must resuscitate the intravascular space, optimize cardiac output, and ensure there isn't a mechanical issue like a clot in the Foley catheter or a bilateral ureteral injury first.
Okay, assuming the central venous pressure is optimized, stroke volume variation is low, and the Foley is clear, what are the exact diagnostic triggers for KDIGO?
KDIGO defines AKI through any one of three pathways. Pathway 1, an absolute increase in serum creatinine of 0.3 milligrams per deciliter or more within a 48-hour window.
Okay, the 0.3 bump.
Right. Pathway 2, a relative increase in serum creatinine to 1.5 times the patient's baseline, presumed to have occurred within the prior 7 days.
And the urine output.
Pathway 3, urine output of less than 0.5 milliliters per kilogram per hour for 6 consecutive hours.
Got it.
Once a patient meets any of these, they are staged from 1 to 3 based on the severity of the creatinine spike or the duration of the oliguria. And crucially, if you initiate renal replacement therapy for any reason, the patient automatically defaults to KDIGO stage 3.
Okay, let's unpack this. While KDIGO is fantastic for standardizing large multi-center retrospective trials, I constantly question its bedside utility for the surgeon standing there looking at a single, highly complex patient. Let's critically evaluate the methodological limitations of relying solely on KDIGO in the SICU.
The primary critique of KDIGO is that it is a purely syndromic classification. It completely fails to discriminate based on underlying etiology or pathophysiology.
It just groups everyone together.
Exactly. KDIGO stage 2 looks identical on paper whether the cause is a functional drop in glomerular hydrostatic pressure from acute cor pulmonale or profound structural necrosis of the renal tubules from rhabdomyolysis.
It tells you the kidney isn't working, but offers absolutely zero guidance on why, which is what dictates your surgical management.
Precisely. And the urine output criteria is arguably the most easily manipulated metric on the entire flow sheet.
Urine output is exquisitely sensitive, which is why it's included, but its specificity in the SICU approaches zero.
Because we constantly manipulate urine output, we administer loop diuretics, osmotic agents like mannitol for elevated intracranial pressure, and massive volumes of unbalanced crystalloids.
Right. A patient might have a urine output of 0.2 milliliters per kilogram for 4 hours, but then you administer 40 milligrams of intravenous furosemide and they dump 2 liters.
Their underlying renal perfusion hasn't improved one bit, but they suddenly no longer meet the KDIGO criteria for AKI based on urine output?
The numbers lie to you. And there's also a highly practical mathematical debate regarding that zero point 0.5 milliliters per kilogram calculation. In a nation battling an obesity epidemic, do we use actual body weight or ideal body weight for that denominator?
Oh, it alters the staging significantly. If you have a patient weighing 150 kilograms, calculating zero point 0.5 milliliters based on actual body weight demands a urine output of 75 milliliters an hour just to avoid an AKI diagnosis.
75 an hour is a lot for a stressed kidney.
It is. If you use their ideal body weight of 75 kilograms, the threshold is only 37.5 milliliters an hour. The literature demonstrates that using actual body weight is highly specific.
Meaning you get very few false positives for AKI.
Right, but it lacks sensitivity. Using ideal body weight catches more true injuries but increases false positives. In clinical practice, utilizing ideal body weight for the urine output denominator prevents you from overdiagnosing oliguric AKI in the morbidly obese trauma population.
That's a huge clinical pearl. What about the scenario of the unidentified trauma patient? A John Doe is brought in after a high-speed motor vehicle collision. No medical history, no prior labs in the system. To use the KDIGO relative creatinine criteria, you need a baseline. What is the validated workaround when you have absolutely zero outpatient data?
Well, relying on the admission creatinine in a trauma patient is dangerous because they may already be hypoperfused or, conversely, hemodiluted from massive pre-hospital crystalloid administration.
So what's the workaround?
In the total absence of a reliable recent outpatient baseline, the established workaround is to reverse calculate a presumed baseline utilizing the MDRD equation.
How does that work in practice?
You plug in the patient's demographic data, age, sex, race, and you mathematically assume they had a normal, healthy estimated GFR of 75 milliliters per minute per 1.73 square meters prior to the injury.
You just give them a flat eGFR of 75.
Yes, and you solve the equation backward to generate a theoretical baseline serum creatinine. It is an imperfect estimate, but it provides a standardized starting point to calculate the 1.5 times baseline KDIGO trigger.
Looking forward, the sheer unreliability of creatinine is really driving the search for novel biomarkers. The text references the 2020 JAMA consensus statement by Osterman and colleagues regarding agents like cystatin C, NGAL, and TIMP2.
Yes, these are the future.
While these aren't ubiquitous standard of care yet, they represent a future where we measure actual tubular stress and damage in real time, rather than waiting 48 hours for a functional marker like creatinine to slowly accumulate in the blood.
Exactly. Biomarkers will eventually allow us to move from reacting to a loss of filtration to proactively treating tubular cellular stress before the filtration ever drops.
Until that day comes, we have to transition from population-level staging criteria back to the physiological reality of the patient right in front of us. When the urine output drops, we classically group the pathology into prerenal, intrinsic, and postrenal etiologies to guide our therapeutics.
This triad is the absolute foundation of clinical nephrology in the ICU.
Let's break them down.
Prerenal AKI is entirely driven by renal hypoperfusion. The kidney tissue is structurally intact, but it is starving for flow and pressure.
In our patient population, this is hemorrhagic shock.
Hemorrhagic shock, severe third spacing of fluids into the abdomen, profound systemic vasodilation from sepsis, or cardiogenic shock from a blunt cardiac injury.
Right. And intrinsic.
Intrinsic AKI indicates frank structural damage to the renal parenchyma. This encompasses acute tubular necrosis, or ATN, driven by prolonged ischemia that wasn't reversed in the prerenal phase.
A classic progression.
Yes, alongside toxic injuries from antibiotics, contrast dye, or the massive pigment loads generated by crush injuries and rhabdomyolysis.
And finally, postrenal AKI.
Postrenal is a mechanical obstruction to urine flow, a clotted Foley catheter, an unrecognized urethral transection from a pelvic fracture, or bilateral ureteral obstruction.
Now, the mechanical postrenal causes are usually ruled out pretty quickly with a bedside ultrasound and just flushing the catheter. The true clinical dilemma is distinguishing between a severe prerenal state that needs more volume and cardiac output optimization versus an established intrinsic ATN where pushing more fluids will only cause pulmonary edema and visceral engorgement. Historically, we rely on the kidney's handling of sodium to make this distinction.
Understanding renal sodium clearance is essential because it is the primary mechanism by which the body defends extracellular fluid volume and systemic tonicity. Sodium is the dominant osmotically active cation in the extracellular space. If renal blood flow or afferent arteriolar pressure drops, the hallmark of a prerenal state, the juxtaglomerular apparatus senses this and aggressively activates the renin-angiotensin-aldosterone system, or RAAS.
Angiotensin II constricts the efferent arteriole to maintain glomerular pressure.
Exactly, while aldosterone drives massive sodium reabsorption in the distal tubules and collecting ducts.
The kidney is desperately holding on to every molecule of sodium, knowing that water will follow in an attempt to restore intravascular volume and blood pressure.
Yes, and consequently, the concentration of sodium in the final excreted urine plummets.
Which brings us to the fractional excretion of sodium, or FeNA. It's the ratio of sodium clearance to creatinine clearance. The classic binary textbook teaching is that a FeNA of less than 1% means the tubules are intact and aggressively reabsorbing sodium, indicating a prerenal volume-depleted state.
That's the textbook, yes.
And if the FeNA is greater than 2%, the teaching says the tubules are necrotic and incapable of reabsorbing sodium, indicating intrinsic ATN. But relying on this binary teaching in the SICU is incredibly dangerous. The FeNA calculation is a trap.
It is a profound physiological trap if applied without context.
Break that down for us.
FeNA was validated in a very specific, narrow cohort of patients with oliguric acute renal failure without confounding medications. In the modern SICU, there are massive limitations.
Diuretics being the big one.
Huge. First, any pharmacologic alteration of sodium transport entirely invalidates the test. If your patient has received a looped diuretic like furosemide, the drug specifically blocks the sodium-potassium chloride cotransporter in the thick ascending limb of the loop of Henle.
It artificially forces sodium out into the urine.
Right. You might have a patient who is profoundly hypovolemic, but because you gave them Lasix 4 hours ago, their FeNA will be falsely elevated to 3%, mimicking ATN.
In that specific scenario, if the patient has been diuresed, what is the alternative to FeNA?
You can calculate the fractional excretion of urea, or furia. Urea reabsorption occurs primarily in the proximal tubule and is linked to passive water reabsorption, which is driven by proximal sodium reabsorption.
And urea isn't affected by the Lasix.
Crucially, urea handling is not significantly affected by loop diuretics acting distally. A furia of less than 35% suggests a prerenal state, even in the presence of diuretics.
But the most insidious trap with FeNA isn't just diuretics. It is how the math falls apart when a patient has a relatively normal GFR.
This is a vital concept for anyone listening. The 1% cutoff for diagnosing a prerenal state is only mathematically valid if the patient already has a significantly reduced GFR.
Because of the massive filtered load of sodium.
Exactly. Consider a patient with a perfectly normal GFR, filtering roughly 180 liters of plasma a day. If they excrete even 1% of that massive filtered sodium load, they would be dumping hundreds of milliequivalents of sodium into their urine daily.
Vastly exceeding their normal dietary intake.
Right. To maintain homeostasis, a normal, healthy kidney must maintain a FeNA well below 1%, often around 0.1 or 0.2%.
So if you consult the FeNA in a patient whose GFR hasn't dropped significantly, it will be less than 1%, purely because they are healthy, not because they are hypovolemic.
Exactly. Blindly bolusing fluids based on a low FeTA in a patient with a near-normal GFR is a guaranteed pathway to iatrogenic volume overload, ARDS, and bowel edema.
That is exactly the kind of deep physiological insight we need. If we can't rely on simple numbers like FeNA or BUN, our strategy in the SICU has to shift entirely toward aggressive, meticulous prevention. We had to protect the kidneys before the injury occurs. The cornerstone of this is hemodynamic optimization. We focus heavily on volume, optimizing preload to boost stroke volume, but establishing an adequate mean arterial pressure, or mean AP, to preserve glomerular hydrostatic pressure is just as critical.
You cannot filter plasma if you do not have adequate driving pressure across the glomerular capillary bed.
Traditionally, the critical care dogma, heavily influenced by early sepsis guidelines, mandated a universal MAP target of greater than 65 millimeters of mercury. But the literature is actively shifting away from this one-size-fits-all approach toward personalized hemodynamic targets. Why does a MAP of 65 fail some patients?
It comes down to individual autoregulation curves. The kidneys can maintain a constant GFR across a range of systemic blood pressures by modulating the resistance of the afferent and efferent arterioles.
But chronic hypertension messes with that curve.
It does. In patients with chronic, poorly controlled hypertension, which is a massive segment of the U.S. trauma demographic, that entire autoregulation curve shifts to the right.
So 65 isn't enough for them.
An MAP of 65 might be perfectly adequate for a healthy 20-year-old, but for a 65-year-old who normally lives with a systolic blood pressure of 170, an MAP of 65 represents profound relative hypotension.
Their kidneys will suffer ischemic injury at a pressure we consider normal.
Exactly. Therefore, modern strategies suggest targeting a MAP that is within 20% of the patient's specific pre-hospital baseline MAP or systolic pressure. Sometimes you need a MAP of 80 or 85 just to achieve baseline renal perfusion.
That requires really digging into their outpatient records the moment they hit the ICU. Now, alongside pressure, we have to talk about the chemical insults we hurl at the kidneys every day. Antibiotics, specifically the workhorse empiric combination of vancomycin and piperacillin tazobactam, or Zosyn. How significant is this specific nephrotoxic threat?
It is a massive, often underappreciated threat. Vancomycin induces nephrotoxicity primarily through direct oxidative stress and tubular cell necrosis. We attempt to mitigate this by monitoring trough levels, typically targeting 10 to 15 milligrams per liter for standard infections.
And pushing to 15 to 20 for severe deep-seated infections like MRSA bacteremia or osteomyelitis.
Right. The incidence of AKI scales directly with the total cumulative dose, the duration of therapy, and specifically the administration of more than 4 grams within a 24-hour period. But the source material highlights a critical pharmacological synergy.
A combination.
Yes, co-administration of vancomycin with piperacillin tazobactam significantly amplifies the risk of nephrotoxicity compared to using vancomycin alongside a cephalosporin like cefepime.
So if you are covering for an open abdomen or a complex soft tissue infection and you see the creatinine creeping up, breaking apart that vancomycin combination and rotating to vancomycin or utilizing linezolid might be the maneuver that saves the patient from dialysis.
It's a very proactive, smart swap.
What about the aminoglycosides? We still use them frequently for multi-drug-resistant gram-negative pneumonias or complex intra-abdominal catastrophes.
Aminoglycosides are highly toxic because they actively concentrate in the renal cortex, leading to a classic non-oliguric acute tubular necrosis. The mechanism of uptake into the tubular cells is saturable.
Meaning you can overwhelm the uptake pathway.
Exactly. Because of this, the modern evidence-based approach strongly advocates for extended interval or once-daily dosing regimens. By giving one massive dose, you achieve the high peak concentration necessary for concentration-dependent bacterial killing, but you saturate the renal tubular uptake mechanisms quickly.
So the excess drug just stays in the blood and gets cleared.
Yes. The prolonged trough period allows the drug to wash out of the renal cortex, significantly limiting total nephrotoxicity without sacrificing antimicrobial efficacy compared to the older, divided multiple daily dosing strategies.
Let's address what is arguably the most contentious topic between the trauma bay and the radiology suite. The CT scanner and the myth of contrast-induced nephropathy.
Oh, this is a big one.
I cannot count the number of times a life-saving CT angiogram for a suspected aortic injury or a mesenteric bleed has been delayed because a resident saw a creatinine of 1.6 and panicked about the contrast dye.
It happens every day.
The source material uses the American College of Radiology and the National Kidney Foundation consensus statement to entirely dismantle this old dogma.
This is a monumental paradigm shift that every practicing surgeon must internalize. The consensus statement unequivocally concludes that the true incidence and severity of acute kidney injury directly caused by intravenous iodinated contrast has been vastly, historically overstated.
It's a myth built on bad data.
Yes. The terror surrounding contrast dye is largely based on a glaring methodological flaw in older legislative literature.
Break down that methodological flaw. How did we get it so wrong for decades?
It was a profound lack of appropriate control groups. Historical observational studies simply tracked patients who received contrast and measured their creatinine. If it went up, they blamed the contrast.
They completely failed to account for confounding by indication.
Exactly. Sick patients get CT scans. Sick patients also develop acute kidney injury because they are hypotensive, septic, or bleeding.
Oh.
Without a control group of equally sick patients who didn't get contrast, these legacy studies could not differentiate between contrast-induced AKI.
Meaning the dye actually caused the cellular damage.
Right. And contrast-associated AKI, meaning the AKI simply occurred in the same temporal window as the scan, but was actually driven by the underlying traumatic shock.
It's the classic correlation versus causation error.
Precisely. To truly diagnose contrast-induced AKI, you have to meticulously exclude all other potential hemodynamic and nephrotoxic insults, which is virtually impossible in a polytrauma patient.
So what does the modern data show?
The modern literature, utilizing large propensity-matched cohorts comparing patients who received contrast versus those who underwent unenhanced imaging, shows virtually no independent increased risk of AKI attributable to the intravenous contrast itself, particularly with the modern agents. We no longer use the highly toxic, high osmolality agents of the 1980s. The current low osmolality and iso-osmolar contrast media are remarkably safe.
So the definitive surgical directive here is clear. The contraindication for intravenous contrast in a patient with reduced renal function is relative, and in the setting of trauma, it is virtually never absolute.
Never.
If you have a patient with a mechanism concerning for a blunt aortic injury, an active retroperitoneal hemorrhage or ischemic bowel, withholding the scan based on a creatinine level is a failure of care. You get the scan, you identify the life-threatening surgical pathology, and you manage the kidneys later.
Absolutely. The risk of missing a surgical catastrophe exponentially outweighs the negligible risk of contrast-induced renal injury. Get the scan.
Before we move off prevention, we have to look at the pharmacological graveyard. Over the years, critical care physicians have tried dozens of potions to force the kidneys to work or to protect them from injury.
And the high-quality data has systematically killed them off.
Let's run through them. N-acetylcysteine, or NAC.
NAC was widely administered alongside intravenous fluids to prevent contrast nephropathy, based on the theory that it provided antioxidant protection to the tubules. However, robust, large-scale, randomized controlled trials have definitively proven NAC to be entirely ineffective compared to placebo. It is no longer recommended.
Dead. What about the classic maneuver of running a low-dose dopamine drip to improve renal blood flow?
Renal dose dopamine is a thoroughly debunked concept. It does not prevent AKI, it does not reduce the need for dialysis, and it can induce significant arrhythmias. It should never be used for renal protection.
Also dead. And Lasix.
The 2012 KDIGO guidelines state unequivocally that loop diuretics like furosemide and osmotic diuretics like mannitol do not prevent or treat ischemic acute tubular necrosis. You use loop diuretics strictly to manage volume overload and optimize cardiopulmonary status, not to protect the renal tubules.
So what actually works?
Ultimately, the only proven pharmacological strategy to preserve renal function, particularly before high-risk procedures or contrast exposure in stable patients, is volume expansion with intravenous isotonic crystalloids to ensure adequate tubular flow and limit neurohormonal activation.
Fluids. Just fluids. Let's shift gears and tackle some specific high-stress scenarios. I want to simulate the 2 a.m. calls from the SICU fellow. We'll do a clinical Q&A leaning heavily on the trial data and physiological mechanisms.
Sounds good. Let's hear them.
Scenario 1. You have a 60-year-old patient, post-op day 2 from an exploratory laparotomy and bowel resection for ischemic gut. They are profoundly acidotic. The arterial blood gas shows a pH of 7.15, the lactate is 6.0, and they are on escalating doses of norepinephrine. The fellow asks, do I push sodium bicarbonate to fix the pH? This has been fiercely debated for decades. What does the highest level of evidence tell us?
The routine administration of sodium bicarbonate in the setting of severe lactic acidosis is fraught with physiological controversy, primarily because correcting the extracellular pH doesn't necessarily fix the intracellular environment or the underlying perfusion deficit. The definitive modern data on this comes from the BICAR ICU trial.
Walk us through BICAR ICU.
It was a multi-center, randomized controlled study evaluating patients with severe metabolic acidosis defined as a pH of less than 7.3. They randomized patients to either receive a targeted 4.2% sodium bicarbonate infusion aimed at correcting the pH to above 7.3 or a control group that received no bicarbonate therapy.
And what was the primary outcome for the general ICU population?
For the overall study population, administering sodium bicarbonate showed absolutely no statistically significant improvement in the primary composite outcome, which was defined as survival free of organ failure at day 7 or overall mortality at day 28.
So pushing bicarb did not save lives in the general cohort.
It did not. The reflexive action of giving bicarb just to make the blood gas look prettier doesn't alter the patient's overall trajectory.
But is there a specific subpopulation within that trial where the data flips?
There is, and this is where careful literature analysis directly impacts bedside care. The investigators predefined a specific subgroup, patients who had severe concurrent acute kidney injury, specifically an AKIN score of 2 or 3 at the time of enrollment.
Okay, the severe AKI group.
Yes. When they isolated that specific severe AKI cohort, the results were striking. Survival at 28 days was significantly better in the group receiving bicarbonate therapy compared to the control group.
What were the actual numbers?
The survival rate was 54% in the bicarb group versus only 37% in the control group, generating a highly statistically significant p-value of 0.028. Additionally, the bicarb group in this AKI subset had a significantly lower requirement for renal replacement therapy.
54% versus 37%. That is a massive, absolute risk reduction in mortality for that specific subset.
It is. However, the source text and the trial authors emphasize that bicarbonate therapy is not benign. It carries severe risks. Hypernatremia, volume overload from the sodium content, and crucially, paradoxical intracellular acidosis.
Let's explain that one.
When you give bicarbonate, it binds with free hydrogen ions to form carbonic acid, which rapidly dissociates into water and carbon dioxide. If the patient is mechanically ventilated and cannot increase their minute ventilation to blow off that excess CO2,
the CO2 freely diffuses across cell membranes into the intracellular space.
Exactly, where it reassociates into acid, worsening the intracellular pH despite the blood gas looking better. But if you have a patient with profound metabolic acidosis and severe established AKI, the bicar ICU data strongly suggests a survival benefit to carefully targeted alkali therapy.
Excellent. Scenario 2. Hyperkalemia. It's 4 a.m. The lab calls with a critical potassium of 5.8 milliequivalents per liter. The telemetry monitor is beeping. What is the physiological threshold for genuine cardiotoxicity, and what is the exact sequence of pharmacological maneuvers?
Hyperkalemia causes immense anxiety, but the physiological reality is that true. Lethal cardiotoxicity is uncommon if the serum potassium concentration remains below 6.5 milliequivalents per liter, assuming a normal rate of rise.
Okay, 6.5 is the real danger zone.
Generally, yes. However, emergent aggressive treatment is absolutely mandated for any potassium level greater than 5.5 if the patient is exhibiting severe symptoms like sending muscle weakness, or, crucially, if there are hyperkalemic changes on the electrocardiogram.
Peak T waves, loss of the P wave, or widening of the QRS complex.
Right. If you see those EKG changes, the absolute first step, a non-negotiable first step, is myocardial cell membrane stabilization with intravenous calcium, either calcium gluconate or calcium chloride.
You are not lowering the potassium level with this maneuver.
Not at all. You are antagonizing the membrane effects of hyperkalemia to prevent ventricular fibrillation. Only after the myocardium is stabilized do you initiate therapies to temporarily shift potassium from the extracellular space into the intracellular space.
Shifting agents.
Yes. This involves administering intravenous regular insulin co-administered with dextrose to prevent hypoglycemia, utilizing nebulized high-dose beta-adrenergic agonists like albuterol, or giving sodium bicarbonate if the patient is concurrently acidotic.
And it is vital for you to remember that shifting the potassium into the cells does not reduce the patient's total body potassium burden. It buys you time. To actually remove the potassium, you need loop diuretics, which are only effective if the kidneys are still producing urine.
Or you can use enteric potassium-binding resins, but those are frequently contraindicated in SICU patients due to recent bowel anastomosis, ileus, or the risk of colonic necrosis.
Right. If the kidneys have failed and the potassium continues to rise despite shifting, you are rapidly marching toward the need for renal replacement therapy.
Which perfectly sets up the transition to predicting that need.
Exactly. Scenario 3. You have a patient who is persistently oliguric despite adequate volume resuscitation. Their creatinine is slowly climbing. You are staring at the Foley catheter, trying to decide if this kidney is going to wake up or if you need to start placing a dialysis catheter. How do we prognosticate the recovery of the renal tubules?
We utilize the furosemide stress test, or FST. This is a brilliant, elegant, bedside physiological tool designed to test the functional integrity of the renal tubules, specifically the loop of Henle.
How does it work?
You administer a standardized weight-based dose of intravenous furosemide, 1 milligram per kilogram for loop diuretic-naive patients, or 1.5 milligrams per kilogram for those with prior exposure.
But giving a massive dose of Lasix to a critically ill patient carries the risk of plunging them back into hypovolemia, compounding the renal insult. How do you execute this safely?
The safety mechanism is mandatory one-to-one fluid replacement. You instruct the nursing staff to match every milliliter of urine output over the testing period with an equal volume of intravenous crystalloid.
So you're maintaining their volume perfectly neutral.
Yes. This isolates the test to tubular function rather than volume status. Once the furosemide is given, you measure the total urine output over the subsequent 2 hours.
What defines a pass or fail?
If the patient produces less than 200 milliliters of urine over those 2 hours, they have failed the stress test.
Less than 200 milliliters.
Right. That failure indicates profound structural tubular injury. The drug reached the thick ascending limb, but the cells were too necrotic to respond. Clinical studies show that failing the FST places the patient at a remarkably high risk for progression to KDIGO stage 3 AKI and a very high likelihood of eventually requiring continuous renal replacement therapy.
It allows the surgeon to stop hoping for a spontaneous recovery and start proactively planning for dialysis access and modality selection.
Exactly.
That brings us to the most fiercely debated, practice-altering topic in modern critical care nephrology: the precise timing of when to initiate renal replacement therapy. Let's clearly define the boundaries of this debate. There are universally accepted, absolute emergent indications for RRT.
The AEIOU criteria.
If a patient has severe refractory metabolic acidosis, hyperkalemia with EKG changes, unresponsive to medical therapy, dialyzable toxic congestions, uremic encephalopathy or pericarditis, or life-threatening volume overload causing refractory hypoxemia from pulmonary edema, the debate is over. You call nephrology, you drop a wide-bore central line, and you start the machine immediately.
Exactly. The massive controversy in the literature, the question that has driven thousands of enrollments in multi-center trials over the last decade, centers entirely on the elective initiation of RRT.
The elective initiation.
Yes. If you have a patient who is oliguric, their BUN and creatinine are steadily climbing, and they have met KDIGO stage 2 or 3 criteria, but they do not yet have those absolute life-threatening emergent indications.
Do we initiate RRT early, proactively cleaning the blood and controlling the metabolic milieu? Or do we implement a delayed, watchful waiting strategy, holding off until an emergent indication develops, hoping the kidneys recover spontaneously?
For a long time, the surgical reflex was to start early. We are interventionists. We see a deranged lab value. We want to fix it.
But the source material provides a rigorous breakdown of 4 monumental data points that have entirely reshaped this paradigm. Let's dissect these trials, starting with the AKII trial.
The AKII trial, published by Gaudry and colleagues in 2016, was a landmark multi-center randomized controlled trial. They enrolled 620 critically ill patients who had severe KDIGO stage 3 AKI, primarily driven by ischemic ATN or sepsis.
And none of these patients had emergent indications.
Crucially, no. None of them had life-threatening emergent indications for dialysis at the time of enrollment. They randomized them into 2 arms. An early strategy, where RRT was initiated immediately upon randomization, versus a delayed strategy.
And what triggered RRT in the delayed group?
In the delayed arm, patients were closely monitored, and RRT was only initiated if they developed severe hyperkalemia, profound acidosis, refractory pulmonary edema, or if they remained oliguric or anuric for more than 72 hours post-randomization.
What was the primary endpoint and what did the statistics show?
The primary outcome was 60-day overall mortality. The result was absolutely no statistically significant difference between the 2 strategies. Mortality was 48.5% in the early initiation group and 49.7% in the delayed group, generating a completely insignificant p-value of 0.79.
So starting the machine immediately didn't save a single extra life compared to waiting?
Right, but there's a statistic from the delayed arm of the AKII trial that should completely alter how a surgeon views elective dialysis.
Let's hear it.
This is the critical takeaway. 49% of the patients randomized to the delayed strategy never ended up needing RRT at all. Their kidneys recovered spontaneously.
Nearly half of them.
Almost half. If those patients had been randomized to the early group, half of them would have been subjected to the invasive risks of a large-bore central line, regional or systemic anticoagulation, and the hemodynamic stress of an extracorporeal circuit for absolutely 0 physiological benefit.
That is a staggering number. But a critic might argue that the AKII trial included a broad general ICU population. What about our sickest of the sick? What about the patient in profound septic shock on multiple vasopressors? Surely they benefit from early clearances of inflammatory cytokines and uremic toxins.
That specific question was answered by the second major trial highlighted in the text, the IDEAL ICU trial, published by Barber and colleagues in 2018. The study design here is paramount.
How is it different?
They exclusively enrolled patients who were in established septic shock requiring vasopressors and who had severe AKI, defined by the Rifle failure criteria, which mirrors KDIGO stage 3. They compared an early RRT strategy, initiated within 12 hours of meeting criteria, against a delayed strategy which waited at least 48 hours.
Did isolating the septic shock population change the outcome?
It did not. The primary outcome was mortality at 90 days. The early group had a mortality of 58%, while the delayed group was 54%. The p-value was 0.38. Again, no statistically significant difference.
So it actually favored the delayed group numerically, though not statistically.
Right. The trial was actually stopped early for futility because it was so clear that early initiation was not providing a survival benefit. And mirroring the AKII trial, 38% of the patients in the delayed arm spontaneously recovered and avoided RRT entirely.
So we have two large, well-designed RCTs showing no benefit to early initiation. Let's layer on the 2020 systematic review and meta-analysis by Gaudry.
The meta-analysis pooled data from 9 studies, encompassing nearly 1,900 patients. It confirmed the findings of the individual trials on a massive scale. The 28-day mortality was virtually identical, 43% in the early strategies versus 44% in the delayed strategies, with a p-value of 0.80. The data overwhelmingly supports the safety of a watchful waiting approach.
But the final data point, the START-AKI trial, moves the needle from early RT is unnecessary to early RT might actually be harmful. Let's dive deep into START-AKI because it is the definitive multinational nail in the coffin for indiscriminate early dialysis.
The START-AKI trial, published in 2020, is an absolute behemoth of critical care literature. They enrolled 2,927 ICU patients across 168 hospitals internationally. These patients had KDIGO stage 2 or 3 AKI without emergent indications.
Huge power for this trial.
Massive. They randomized them to an accelerated strategy starting RT within 12 hours versus a standard strategy where RT was initiated at the clinician's discretion, usually upon the development of emergent indications or prolonged failure to recover.
And the primary outcome?
Predictably, based on the previous trials, there was no difference in 90-day all-cause mortality. It was 43.9% in the accelerated group and 43.7% in the standard group, with a p-value of 0.92.
But let's look at the secondary outcomes, specifically the adverse events. This is where the story shifts dramatically.
Yes. The START-AKI trial revealed that the accelerated early RRT group suffered a statistically significant, objectively higher rate of severe adverse events.
What were the numbers?
The rate was 23.0% in the early group compared to 16.5% in the standard group, with a highly significant p-value of less than 0.001.
What exactly were these adverse events causing harm to the early RT patients?
The primary drivers were an increased incidence of severe hypophosphatemia, profound hypotensive episodes directly related to the initiation of the extracorporeal circuit, and an increased rate of significant bleeding complications.
Let's contextualize why that happens. If you throw a patient on continuous then novenous hemodiafiltration simply because their creatinine is 3.0, the machine doesn't just pull urea.
No, it pulls everything.
It aggressively strips the blood of water-soluble vitamins, trace minerals, and critical electrolytes like phosphorus. Severe hypophosphatemia leads to profound respiratory muscle weakness, making liberation from the ventilator nearly impossible.
Exactly.
And the extracorporeal circuit requires a massive volume of blood to prime and run, which drops the patient's preload, inducing hypotension that requires more vasopressors.
Which paradoxically worsens the ischemia to the native kidneys you were trying to protect.
Right. And to keep that circuit from clotting, you are running regional citrate or systemic heparin, directly contributing to the bleeding complications in a patient population that may already be coagulopathic from trauma or liver failure.
The physiological toll of running the therapy is massive. When you synthesize the AKII, Ideal ICU, and START-AKI trials, the conclusion is undeniable. Broadly initiating elective RRT early, without thoughtful, individualized patient stratification, does not improve survival.
It wastes resources.
It wastes incredibly expensive ICU resources, it ties up specialized nursing staff, and it actively harms a significant portion of your patients by subjecting them to the inherent complications of the circuit.
The decision to initiate elective RRT must be a deliberate, multidisciplinary discussion, weighing the specific trajectory of the patient against the very real risks of the therapy. That is precisely how we need to interpret and apply the literature.
Completely agree.
Now, assuming the patient has reached an absolute indication, or they have failed a watchful waiting strategy and require RRT, The immediate next hurdle for the surgeon is choosing the modality. You can't just write an order for dialysis and walk away. We have to match the physics of the machine to the physiology of the patient. Let's break down the physical principles of solute and fluid clearance.
Understanding the physics allows you to tailor the prescription. All forms of RRT rely on transporting water and solutes across a semi-permeable membrane within the dialyzer filter. There are three fundamental physical principles utilized: ultrafiltration, diffusion, and convection.
Let's start with ultrafiltration, which is purely about fluid management.
Ultrafiltration, or UF, relies entirely on a hydrostatic pressure gradient known as the transmembrane pressure. By increasing the pressure on the blood side of the membrane relative to the dialysate or ultrafiltrate side, water is physically forced across the pores. This is the sole mechanism by which we remove volume from a fluid-overloaded patient.
Next is diffusion, the classic mechanism of standard hemodialysis.
Diffusion achieves solute clearance by exploiting a concentration gradient. Inside the filter, you run the patient's blood in one direction and a specialized dialysate fluid in the opposite countercurrent direction. Small molecules, specifically those with a molecular weight under 500 daltons, such as urea, potassium, and creatinine, diffuse rapidly across the membrane from an area of high concentration in the blood to an area of zero concentration in the dialysate.
And the efficiency of diffusion is highly dependent on the blood and dialysate flow rates.
Exactly.
Finally, we have convection, which is a slightly more complex principle heavily utilized in continuous therapies.
Convection relies on the physical flow of water to drag solutes with it. As you utilize high-volume ultrafiltration to pull plasma water rapidly across the membrane, it creates a solvent drag effect. The water physically pulls solutes through the pores.
Why is that important clinically?
Crucially, while diffusion is limited to small molecules, convection is capable of clearing medium to large molecular weight solutes up to the pore size limit of the membrane. This means convection can effectively clear larger inflammatory mediators, tumor necrosis factor, vitamin B12, and complex uremic toxins that diffusion alone cannot efficiently eliminate.
Armed with those physical principles, let's look at the menu of modalities. First up is standard intermittent renal replacement therapy, or IRT. This is your classic 3 to 4 hour hemodialysis run. What is the specific appeal, and what is the massive, potentially lethal downside for the surgical patient?
The primary appeal of IRT is sheer speed and efficiency. Because it utilizes extremely high blood flow rates, often 300 to 400 milliliters per minute, and high dialysate flows, it provides incredibly rapid correction of severe, life-threatening electrolyte disturbances like a potassium of 7.5. It can quickly clear dialyzable toxic ingestions like lithium or toxic alcohols. However, the surgical downside is profound hemodynamic instability. You are attempting to remove a massive amount of solute and liters of fluid in a very condensed 4-hour window. This rapid reduction in intravascular volume outpaces the body's ability to refill the vascular space from the interstitium, causing profound systemic hypotension in 20 to 30% of IRT treatments in the ICU.
But the hemodynamic instability isn't the only risk. Let's talk about the specific danger IRT poses to a trauma patient with a severe traumatic brain injury.
This is a critical contraindication. When IRT rapidly clears urea and other osmol from the intravascular space over 3 hours, the plasma osmolality drops precipitously. However, urea crosses the blood-brain barrier slowly,
Creating a gradient.
Yes. This creates a massive, sudden osmotic gradient between the relatively hypotonic plasma and the still hypertonic brain tissue. Water shifts rapidly along that gradient, crossing the blood-brain barrier into the cerebral parenchyma, causing acute cerebral edema and an immediate spike in intracranial pressure.
In a TBI patient who already has diminished intracranial compliance, standard IRRT can cause catastrophic herniation.
It's extremely dangerous.
Because of these extreme physiological shifts, surgical intensivists vastly prefer continuous renal replacement therapy, or CRRT. It runs 24 hours a day, pulling fluid and solute gently, mimicking the slow, continuous action of the native kidneys.
Exactly. CRI utilizes much lower blood flow rates, typically 100 to 200 milliliters per minute, providing unparalleled hemodynamic stability. It allows you to slowly remove liters of fluid over 24 hours without causing hypotensive crashes. The text details 4 primary CRRT modalities, progressing in complexity based on the physical principles we discussed.
Let's run through them. First is SCUF.
SQF stands for slow, continuous ultrafiltration. There is no dialysate and no replacement fluid. It relies purely on the principle of ultrafiltration to slowly remove plasma water. It is utilized almost exclusively for the isolated management of severe volume overload in a patient whose electrolytes and urea are otherwise acceptable. For example, severe congestive heart failure refractory to diuretics.
Next is CVVH, continuous venovenous hemofiltration. This is where convection takes center stage.
In CVVH, there is no dialysate running countercurrent to the blood. Solute clearance is driven almost entirely by high-volume convection. You use immense transmembrane pressure to pull large volumes of ultrafiltrate across the membrane, dragging the medium and large molecular weight solutes with it.
But because you are pulling off liters of plasma water an hour to achieve that clearance, you must administer a sterile replacement fluid directly back into the patient's bloodstream to prevent profound, immediate hypovolemia. And there's a highly technical nuance regarding that replacement fluid in CVVH that the ordering surgeon needs to dictate. Running the fluid pre-filter versus post-filter. Why does this matter?
It directly impacts the lifespan of your extracorporeal circuit. If you infuse the replacement fluid post-filter, meaning you return the fluid to the blood after it has passed through the dialyzer, the blood traveling through the actual hollow fibers of the filter becomes extremely hemoconcentrated.
Because you pulled all the water out.
Right. You are pulling water out, leaving the red blood cells and platelets packed tightly together. If the filtration fraction, the ratio of ultrafiltrate removed to the total plasma flow, exceeds roughly 25 to 30%, the risk of the filter clotting off becomes unacceptably high, destroying the circuit and causing the patient to lose the blood trapped within it.
So to prevent the filter from clotting, you run the replacement fluid pre-filter.
Correct. Infusing the replacement fluid pre-filter dilutes the blood before it enters the hollow fibers, drastically reducing the hemoconcentration and extending the life of the filter, which is crucial if you are trying to minimize heparin or citrate use.
But there is a trade-off.
There is. Because you are diluting the blood prior to filtration, you decrease the concentration gradient of the solutes you're trying to remove, effectively reducing your overall solute clearance efficiency by up to 15%. It is a constant clinical balancing act between maximizing circuit lifespan and maximizing clearance efficiency.
Let's round out the CRRT acronyms. We also have CVHD, continuous venovenous hemodialysis, which utilizes low-flow continuous dialysate countercurrent to the blood, relying primarily on diffusion for small molecule clearance. And finally, the workhorse of many trauma ICUs, CVVHDF, continuous venovenous hemodiafiltration.
The big one.
Right. It utilizes both high-volume convection and continuous dialysate diffusion to provide maximal clearance of small, medium, and large molecules. Now, CRRT is hemodynamically gentle, but it requires massive resources. Specialized machines, expensive proprietary fluids, and one-to-one specialized nursing care. Furthermore, the patient is tethered to the machine 24/7. Is there a hybrid modality?
Yes, the text introduces prolonged intermittent renal replacement therapy, or PIRT. You can think of it as a physiological middle ground. You utilize the standard conventional hemodialysis machines used for IRT, but you run them at significantly lower blood and dilysate flow rates over an extended period, typically 6 to 12 hours.
What is the clinical advantage of PIRT?
It offers the hemodynamic stability and gentle solute clearance approaching that of CRRT, but because it only runs for 12 hours, it frees up the patient for the other half of the day. This is critical in the SICU. It allows the circuit to be disconnected so the polytrauma patient can travel to the CT scanner, undergo interventional radiology procedures, or return at the operating room for a planned abdominal washout without sacrificing an entire day of necessary dialysis therapy or tying up specialized CRRT equipment.
Ultimately, when we look at the mortality data comparing CRRT and CARES-CARE, what is the final verdict?
The verdict derived from multiple massive meta-analyses is unequivocal. There is no distinct overarching survival benefit ascribed to any single modality. CRT does not inherently save more lives than IRT. Therefore, the choice of modality must be tailored entirely to the patient's unique physiological state.
Tailored care.
Always. If you have a patient on 3 vasopressors, or a patient with a TBI and elevated intracranial pressure, CRRT or PRT are mandated for stability. If you have a hemodynamically robust patient who simply has a wildly toxic potassium level, IRT is the fastest, most effective tool. It is a nuanced clinical judgment, not a blanket protocol.
We are nearing the end of this deep dive into the evidence, but we must address the final, often overlooked chapter: long-term outcomes and the handoff. We expend an incredible amount of energy, resources, and intellectual capital to get these patients out of the SICU alive. But the grim reality of AKI follows them long after they transfer to the floor.
The long-term statistics are sobering and demand a change in how we view the continuum of care. For patients who fail to recover their renal function while in the hospital, the in-hospital mortality rate remains at a devastating 47%.
47%.
Yes. But even for those who do survive, recover enough to come off dialysis, and are discharged home, the physiological scar remains. They are at a drastically elevated risk for recurrent AKI episodes, relentless progression to end-stage renal disease requiring permanent outpatient dialysis, severe refractory hypertension, and major cardiovascular events like decompensated heart failure and myocardial infarction.
And this elevated risk profile leads to a massive systemic follow-up failure that we, as the discharging surgical intensivists, need to acknowledge and correct.
The failure is profound. The 2012 KDIGO guidelines explicitly recommend that all patients who survive an episode of AKI, regardless of whether they require dialysis, must follow up with a nephrologist within 90 days of hospital discharge.
Within 90 days.
Yes. The data supporting this recommendation is incredibly powerful. Simply being evaluated in a nephrology clinic, optimizing blood pressure medications, and reviewing outpatient labs in that 90-day window reduces their 2-year mortality by an astonishing 24%.
A 24% absolute reduction in 2-year mortality from a single clinic visit.
Exactly. Yet, despite this massive, proven survival benefit, the source text reports that national follow-up rates for AKI survivors are as low as 41%. More than half of these high-risk patients are falling through the cracks of the healthcare system.
To every surgeon and intensivist listening, this is your actionable, practice-changing advice for today. Your job as a physician is not complete the moment the patient transfers to the step-down unit or walks out the hospital doors. Discharge planning for an AKI survivor is quite literally a matter of long-term life or death. We must ensure that a dedicated nephrology appointment is booked, confirmed, and communicated to the patient before they ever leave your surgical service.
Our surgical and critical care excellence within the walls of the ICU must be matched by our diligence and rigor in managing care transitions to the outpatient setting.
Let's bring this all home with a final summary. Today, we navigated the incredibly treacherous physiological waters of acute kidney injury in the surgical intensive care unit. We learned that classic markers like BUN and creatinine are frequently distorted by hematoma absorption, muscle wasting, and active tubular secretion.
We discovered that blindly relying on a FENA calculation is a trap if your patient is diuresed or has a normal GFR.
We completely busted the legacy myth of contrast-induced nephropathy. Remember the absolute directive: never delay a life-saving trauma CTA for a bumped creatinine.
We dissected the landmark trials, AKICAI, Ideal ICU, and START AKI, proving definitively that jumping the gun on elective early RRT does not save lives and can actively cause harm through hypophosphatemia and bleeding.
And we mapped the complex physics of RRT modalities to the specific hemodynamic needs of the patient. To apply this to your clinical practice tomorrow, start utilizing the weight-based furosemide stress test to accurately prognosticate tubular recovery. Go back to your hospital and fiercely update your unit's protocols on contrast imaging and trauma to reflect the modern ACR and NKF consensus.
And finally, demand rigorous, data-driven multidisciplinary discussions before anyone places an elective dialysis catheter in your patients. It ultimately comes down to anticipating the complex physiology, constantly questioning established dogmas with high-level trial evidence, and meticulously tailoring every single intervention, whether it is an individualized MAP goal based on pre-hospital autoregulation, a once-daily aminoglycoside strategy, or a specific CVVHDF prescription to the unique patient lying in the bed in front of you.
I want to leave you with one final provocative thought to mull over as you head into your next shift or sinus your patients. We just discussed that a simple outpatient nephrology clinic visit within 90 days reduces a patient's 2-year mortality by an astonishing 24%. Yet less than half of our SICU survivors actually receive that basic level of follow-up care. It forces you to wonder, is the true lethality of acute kidney injury no longer found in the failure of our advanced intensive care science, our dialysis machines, and our vasopressors, but rather in the profound fragmentation of our post-trauma healthcare system?
We can optimize the physiology perfectly in the ICU, but if the system fails them upon discharge, the ultimate outcome remains unchanged.
Thank you for joining us on this deep dive into the evidence. Keep questioning the dogma, keep pushing the boundaries of the science, and most importantly, stay sharp and maintain your critical edge.